Hi, good evening. Dr. Garima here again with the remaining part of the March 2025 questions that were asked in the ADC Part 1 exam. Pretty late here at night, but I wanted to keep the discipline going on of me shooting at least one video in a day. Had a very hectic day, but it's okay. Let's just start, quickly finish this video and give you more knowledge about the kind of questions that have been asked in March 2025 exam. So let's start. Denture planning in medically compromised patient. Now, this particular question you will 100% get in the exam, as there are many old people in Australia and they will be taking some or the other form of anti-resorptive medication, mostly females, because of osteoporosis that sets in. And in such scenarios, our oral cavity is very important, because in old people, usually they come for extraction of teeth. As you age, the teeth itself get worn out or periodontal disease has happened, and then you need to replace them either with implants or with complete dentures, and you have to take care of the remaining bone structure. And when a patient is taking anti-resorptive medication, then it really becomes difficult as to how to plan the treatment and then execute it without having the patient suffer a lot as a side effect of the medicine on the bone, correct? So firstly, you have to understand this chapter very clearly. In Therapeutic Guidelines, they have mentioned the entire guidelines as to when you can work if the patient is taking oral anti-resorptive medication and injection of anti-resorptive medication. The ones which are given by IV line, that's injection, basically of the anti-resorptive medication, write it down in your notes, has more effect on the bone structure. Basically, the bone is not that willing to heal faster compared to the oral form. So basically, the injection part of the anti-resorptive medication has more severe side effects than the oral ones. Remember this always. So that you have to read. You also have to open your textbooks, and any basic OMDR textbook will be fine. And you have to read about the MRONJ drugs, that's bisphosphonate, and MRONJ drugs, okay? So these two drugs you have to read, you have to understand which one belongs to what, you have to remember the brand names of it, and you have to remember them, because if you get confused in them, then you're going to make big mistakes in your exam. And these questions usually are pretty much straightforward. These questions won't have two options correct like we used to have in other questions, right, where you can get confused as to should I choose this answer, should I choose that answer. These questions are pretty much straightforward with one single right answer. So it is of paramount importance that you get these questions correct. Understood? So let's start by solving these, and make a note, make star mark around MRONJ, that's medicine related osteonecrosis induced this thing, and BRONJ, correct? So a 68-year-old female patient is edentulous and presents for complete denture fabrication. Okay, so there is a 68-year-old and she's edentulous, there's no teeth in the mouth. She has severely resorbed mandibular ridges and is currently being treated with denosumab for osteoporosis. She requests a denture that will provide comfort without causing trauma or complications. What is the most appropriate denture-based material for the lower arch in this case? See, if she was not having this medication, denosumab, then pretty much the most stable denture is cobalt chromium, but it is of a metallic framework and it would exert a lot of pressure on the mucosa and the remainder of the bone, causing it to resorb even more. And because she already has a very severely resorbed mandibular ridge, plus she's taking denosumab, then the option of cobalt chromium metal base is out. You just cannot give that, okay? Conventional heat cure acrylic resin, that is an option. It's not a bad option. Flexible denture base is also an option. Soft liner acrylic denture with resilient liner. Implant retained overdenture with locator attachments. Now, if this patient was not having denosumab, then option E would have been a good option also, had the patient be very healthy, because that's the best one, you know. You have something fixed in the mouth and more biting and chewing efficiencies there. But you cannot give implant. I mean, it's not like you cannot give implant, but it's very risky to give implants in denosumab patients, because the bone is not going to heal that fast, and you want to have the least amount of trauma to the mucosa and the bone, because the chances of developing osteonecrosis is very high in such patients. So the minimum the surgery that you do is the best for these patients. So you have to take care of the overall health also. So option E is not here, but if the patient was healthy, then option E would have been the right choice. Now you can be confused between option B and option D, but in such patients where they have severely resorbed mandibular ridges, the chances of them getting resorbed more are even more high. And the patient wants something which is very comfortable, which does not require again and again refabrication. So the option D, soft liner acrylic denture with resilient liner, is the best option, because you can keep on relining the denture as much as possible whenever, up to a point that the denture is no longer viable and you have to replace it, but you can just keep on relining it. Now, I understand, as a dental graduate, it's very rare for you to have come across such a patient, but then these are very normal, common patients in Australia, and if you're going to clear that exam and expect yourself to practice there, then you have to know these things out there. So, all those candidates who are there in Australia at the present moment, and if you are assisting some other dentist, you must be seeing that so many of such patients are coming in your clinic on a regular basis. So if you are the dentist, then you would be expected to have knowledge of this and treat those patients accordingly, correct? So from the Australian standpoint of view, these questions are very rightfully asked in the exam, and you should embrace these questions and learn more about them, so you become more competent with the rest of the population out there. Now, denosumab is a rankle inhibitor used in osteoporosis and metastatic bone diseases. It reduces the bone turnover and carries the risk of medication-related osteonecrosis of the jaw, especially after invasive procedures like extractions of poorly fitting dentures that causes chronic trauma. So, in patients with resorbed ridges, anti-resorptive therapy like denosumab, risk of mucosal ulceration and bone exposure, the appropriate approach is to use a soft line denture, which distributes pressure more evenly, reduces trauma, minimizes the risk of MRONJ, can be relined and monitored regularly. Flexible dentures may seem comfortable but lack adequate ridge support and can worsen pressure on soft tissues in severely resorbed ridges. Metal bases are rigid and offer limited shock absorption. Implant placement is contraindicated or high risk, like I mentioned, in patients on denosumab due to impaired healing and risk of osteonecrosis. So I hope you have understood this question, and I have given the explanation with detailed explanation, I would say, making you understand why we are not choosing the other options, even though you may get confused, like I mentioned, in two options. So now you finally know why. You can of course pause this video, write all these things down, and remember them and study more about it. Please do expect 100% one question, at least one question, I would say. They can ask up to 5 questions on this topic. In each paper they can ask, any number of questions. So be prepared. Now, another question. A 72-year-old patient on denosumab for osteoporosis presents for a lower denture. She has sharp bony undercut that may require reduction for proper denture fit. Now, bony undercut is present in the mouth of the patient, so a denture sometimes cannot fit because there is an undercut. It's difficult for the denture to go in, or even if it goes in, it can hurt the mucosa very badly. So what is the most appropriate management regarding this bony undercut, which is very sharp? Okay. So, schedule surgical bone reduction before denture fabrication. Okay. Proceed with denture fabrication and monitor for irritation. Refer to implant retain prosthesis to avoid tissue pressure. Again, high risk, contraindication, implant, it's out of the window. Avoid surgery, modify denture design to relieve over bone area. Discontinue denosumab and then perform bone trimming. Discontinue denosumab, you are not the general physician for the patient, and you have no right to discontinue any systemic medication that the patient is taking. So option E is also out of the window. So you can be confused with option A, option B, and option D. Alright. Now in this patient, the appropriate management is avoid surgery, because it's a 72-year-old patient and the patient is taking denosumab. You do not want to do anything which can result in the risk of osteonecrosis. So you will modify the denture design to relieve over the bony area. Probably you will give a big relief area over the denture, like how you give for the frenum areas. Maybe you will give a V-shaped relief over that bony undercut. As much as you can, try to avoid any sort of invasive trauma in patients who are taking denosumab or any MRONJ related drugs. That is your first option. If that option fails, like if you give such a denture and that is not working out, it is unstable, it is getting uplifted, the patient is not comfortable, then only you will proceed towards doing something invasive. Otherwise, pretty much in the non-invasive way, whatever problems that you can solve, you are going to solve in such patients. Always remember that, okay? So again, I've given an explanation. You can go through it. And the rest of the 2 questions will continue tomorrow. I do not wish to make videos lasting more than 10 minutes, because I do understand you are studying, and the more longer the video, the less the attention span. And anyways, these are very heavy, profound topics which itself requires your reading a lot. So tomorrow we'll continue on the implant planning in anti-resorptive therapy. Coming to that, I just want to share again this book that is published this month, and I have taken questions from all the ADC resources that were mentioned on their website, having an index of this 21 subjects from these textbooks which are ADC recommended, and making questions about it, SBQs, correct? So I'm sharing few of them on my Target ADC Facebook group. You can go and have a look. And the rest of it, if you would like to have it, you can just email me on adcwrittenmocktest@gmail.com. This book basically, like I was mentioning in previous videos, is like an elevator to your destination, instead of you taking the hard work of walking the stairs, because ultimately your work starts at the destination. You need to have the right resources. So why waste your time going through the stairs when you can just take an elevator, read your place, and then just start studying about it. So anyways, if you like the video, great. Just leave your comments. It's always nice to read them, and have a nice day. Bye bye.